Can't see. Any questions from the audience?
Yes, I see Giuseppe Catenuto.
Giuseppe, please.
So, hello everyone. Thank you for being here in connection. I have a question for Sunny Chatterjee. I really like the breastcalc.org. I use it every day in my clinical practice. My only concern, I find it very useful for autologous versus implant reconstruction. But when it comes to oncoplastic surgery, I believe that oncoplastic surgery is such a big world of surgical techniques, from level 1 to tissue replacement. So hopefully, I'm wondering if the next future there will be any development to include more precise definition of oncoplastic techniques when you use this tool. I'm very committed to popularize it. It's definitely a fantastic tool with a very large set of population that can be even bigger if you want to expand it with European data. Okay, thank you.
No, thank you. That's a very astute observation. The NSQIP ACS database, for the most part, captures level 1, and so the true level 2s aren't as well represented, even though there's a huge sample size and we probably get a good sampling. We are mixing the data of oncoplastics, and that in itself is such a major group of breast surgery types, and it's varied. So you're absolutely right. That is a limitation when you bunch up all oncoplastics after partial mastectomies. I think our initial goal was to just include partial mastectomies, oncoplastics, because there is a BRA calculator that only looks at mastectomies and implant reconstruction and flap reconstruction, but it kind of ignores most of the majority of surgeries, which is breast conservation in at least in many countries, if not the world. So point taken, you're absolutely right. I think there are two things we should certainly look into: expanding on levels of oncoplastics and also looking at long-term complications versus just short-term complications. And that really just depends on the databases we look onto, but happy to collaborate with my European colleagues in that for sure. Thank you.
We had an earthquake, perhaps? Yes? Yeah. Okay, so sorry, Sunny, perhaps there was an earthquake here in Milan.
It more like a subway, underground.
Or the subway.
Or the subway.
we hope the subway. Okay.
A small question for Dr. Kutari. You talked about complications in oncoplastic breast surgery, and you talked that the main theme basically is hypoxemia or hypoxia as the main theme for all the complications. Any thoughts or any experience of using hyperbaric oxygen for these cases, early intervention in chambers? Any thoughts about that?
So that's a great question. And yes, I think there is a role, but we don't have, the only hyperbaric oxygen chamber that we have in London is one. So there's a huge demand from people from different specialties and burns that take priority over complications of oncoplastic breast surgery. So firsthand, I don't have a lot of experience with hyperbaric oxygen, but yes, there is definitely a role, because like you said, and I alluded to, is fat necrosis, skin necrosis, nipple necrosis, they all ultimately come down to poor blood supply or poor venous return. And they're thinking logically, there has to be a role for hyperbaric oxygen in these patients. How much, I can't say, because my personal experience is not that much. We have a couple of cases and that's it. But they worked. In both those cases, they worked.
Audience, please.
Yeah, my name is Peter Kellerman from Hungary, Neo, Budapest. I have a question to Dr. Rea. Your first case was a second breast conserving surgery.
Just a micro.
Yeah, your first case was a second breast conserving surgery, as I saw. What about your recommendation in your country about the second breast conserving surgery? Okay.
Could you please repeat?
Yeah.
On just the question.
Okay. What the recommendations in your country about the second breast conserving surgery related to radiotherapy? Because as I saw, your first case was a second breast conserving surgery.
We offer to the first guidelines are performing mastectomy when you have a relapse in the breast. That's the guidelines everywhere in the world. But now when you have a more than 5 years delay and you have a relapse with only in situ carcinoma, for instance, we know using large data set of relapse on in situ carcinoma that the risk is almost zero. There is no, the survival is very high. So why should I perform a full mastectomy in this case? And I don't want to wait for years of clinical trial. So we discuss and we share the decision with the patient. And some patients are able to cope with that and to go for a second conservative treatment, and some aren't. So it depends on the patient.
And do you have any experience with brachytherapy results or no brachytherapy?
Brachytherapy?
Brachytherapy.
Brachytherapy. Why should I use brachytherapy? Because the other question in all what we see, and I thank you, Dr. Chatterjee, it's really nice what you did, is that why are we performing radiotherapy for a small tumor, a small group of microcalcification within situ? We have to share with the patient. Some patients with a some not. It's a small percentage, but life is like that. We just had an earthquake. Never know what happened. Sometimes it's worse than that. So we have to change the way we discuss. The decision-making process is not in the right position today. We have to discuss more with our patient, and there is multiple of options. So we have to discuss with them.
Okay,
Perfect.
thank you.
Thank you. We have a question from the online system for Mr. Kotari. Is there a role for negative pressure for preventing complication in oncoplastic breast conserving surgery, apart then from treating complications?
It's a good question, but I've asked this question to many of my colleagues. And in high-risk patients, maybe there's a role, but if you think that your negative pressure is going to compromise or compensate for your complications, then unfortunately that doesn't happen.
Yeah.
So the VAC Alta and all the dressings that are used, the Prinio dressings, they're all good for very high-risk women, but then you could argue that in those high-risk women, you shouldn't be offering this kind of complex surgery anyway. So I don't think that there is any proven advantage of spending that kind of money for the dressings, which are very expensive anyway, and they don't give you it doesn't translate into the percentage benefit that you hope it would.
Yes, thank you. Thank you for your answer. Another last question from the audience for Cicero. Is there always the need to remove an exposed implant, or we can use a conservative approach?
Hi, Nicola. Thank you for the question. It is a very good question, and this is a frequent problem in practice, unfortunately. In some series, 10 to 20% of cases, we can, without radiotherapy, previous radiotherapy, and without infection, we can try to put some stitches, and we have published recently a paper with about 50 to 60% of success to maintain the implant in this case, but just for small area of extrusion, not for big area of necrosis and together with infection. And I think that in irradiated, previously irradiated patients, when you have extrusion, it's impossible to save the implant.
Yeah, totally agree with you.
Well, thank you very much for this really interesting session. Thank you guys for joining us online. And we have now here a coffee break, so you can also at the home take some coffee, and we'll be back afterwards for another session. Thank you very much.
Thank you. Bye-bye. Bye-bye, Cicero. Bye-bye, Ash. Bye-bye, Sandy.
Bye, guys. Bye, friends.
Bye-bye.